Yeah, hello. My name is Holger Thiele. I'm a full professor and the director of the Heart Center Leipzig at the University of Leipzig. And my presentation is called Revascularization in Patients with Cardiogenic Shock. I have no relevant disclosures with respect to this presentation. Mainly, we got funding for my institution to perform all the randomized trials we have performed previously or we are currently performing in patients with cardiogenic shock. So what we have learned in patients with cardiogenic shock after an acute myocardial infarction is that early revascularization can reduce mortality. So there were two randomized trials, and altogether they have clearly shown a mortality benefit. And therefore, patients with an acute myocardial infarction like this case, which is from our Culprit shock trial with an acute occluded LAD, severe stenosis of the left circumflex, and a chronic total occlusion of the RCA. This is a patient who needs to be transferred immediately to the cath lab. And based on the anatomy you have just seen, we have different options. So we can go for carpet lesion only PCI. We can go for carpet lesion only plus stage revascularization. We can also go for CABG, and we can also perform immediate multivessel PCI. However, CABG is currently very rarely performed in these patients. And roughly 80% of the patients presenting with acute myocardial infarction and cardiogenic shock have multivessel coronary artery disease, which is much more often than in patients without cardiogenic shock, where only roughly 40 to 50% of the patients have multivessel coronary artery disease. The guidelines, or at least the previous guidelines, gave a 2AC recommendation to perform immediate multivessel PCI in these patients. The American guidelines did not give any recommendation, but the so-called appropriate use criteria said this is a A9, so this is highly appropriate to use multivessel PCI in these patients with cardiogenic shock. However, as you can see it here, this is a meta-analysis done by our group. Only 20% of the patients really in clinical practice undergo immediate multivessel PCI. And in the majority of patients, carpet lesion only PCI is currently performed. And interestingly, in contrast to that, what the guidelines currently say, carpet lesion only PCI, at least according to registries, leads to a significant reduction in mortality in comparison to multivessel PCI. So this patient was randomized in our Culprit shock trial. So we performed PCI of the LAD, we performed PCI of the left circumflex, and we also reopened the right coronary artery in one setting, as you can see it here, which looks nice. And this patient also survived. However, we really do not know, and that's the reason why we have done the so-called Culprit shock trial. It was an investigator-initiated European multi-center trial. I have been the PI and coordinator of the trial, and you can see here the national coordinators of this European-based multi-center trial. So against that, what the guidelines said, there was a significant reduction at 30 days in the primary study endpoint consisting of all-cause mortality or renal replacement therapy. As you can see it here, an absolute 10% reduction with carpet lesion only PCI in comparison to immediate multivessel PCI. And this was mainly driven by an absolute reduction of more than 8% in all-cause mortality at 30 days. So there were many other subgroups we were looking for, also for patients with chronic total occlusions, as you can see it here. And all the subgroups were consistent, showing a significant better outcome for carpet lesion only PCI in comparison to multivessel PCI. And based on this, only a few months later after our presentation, the ESC revascularization guidelines now downgraded the recommendation to immediately perform multivessel PCI, which is now a class 3B recommendation, meaning that you should not do it because it is causing harm to the patient. So I mentioned short-term results previously. Longer follow-up data from registry data showed no difference in mortality, as you can see here. But like always, these are registry data which are prone to bias. And that's the reason why we also had a long-term follow-up in our trial. And as you can see it here, it is remained significantly better for the culprit lesion-only PCI strategy in comparison to the immediate multivessel PCI. And interestingly, and this is what we already know, so patients with cardiogenic shock, mortality is mainly confined to the first 30 days. Thereafter, as you can see from this landmark analysis, mortality still is increasing, so these are still high-risk patients, but there's no difference between culprit lesion-only PCI or the multivessel PCI strategy. So we also have data for patients without cardiogenic shock, also recently published, as you can see it here in the New England Journal of Medicine. The question now is if shock versus no shock patients are different animals. So in this complete trial in patients without cardiogenic shock, cardiovascular death, myocardial infarction, or ischemia-driven revascularization, or cardiovascular death or new myocardial infarction was significantly better with complete revascularization, which at first glance may be contradictory what we have seen in our trial. But we have to look for what has been done in complete and what has been done in the culprit shock trial. So complete compared culprit lesion-only PCI in comparison to culprit lesion-only plus stage revascularization. And stage revascularization plus culprit lesion-only PCI was significantly better than culprit lesion-only PCI. In our trial, we compared immediate multivessel PCI in comparison to culprit plus stage revascularization, as you can see it here, because our study protocol clearly defined that stage revascularization should be performed in patients with angina, with severe lesions, or in patients with ischemia. So, and as you can see it here, roughly 50% of the patients died. And as you can see it here, and another 1/3 of the patients got stage revascularization in the culprit lesion-only PCI arm. So clearly showing that the complete trial, as well as our culprit shock trial, really stage three. So this is maybe the key message. And patients without cardiogenic shock and patients with cardiogenic shock are really very similar. So you should go for culprit lesion only and then do stage revascularization in more significant or severe lesions. So based on all this, what we currently know, this is a review we have done, as you can see here in 2019. So currently, early revascularization is able to reduce mortality. Based on culprit shock, culprit lesion only PCI reduces mortality in comparison to immediate multivessel PCI. Maybe vasopressors norepinephrine is better than dopamine or epinephrine, but this is currently the only evidence we have altogether for a reduction in mortality in patients with cardiogenic shock. So in summary and conclusion, so you should go for culprit lesion only PCI plus stage revascularization. There may be some exceptions if you have no identifiable culprit lesion, if you have more than one culprit lesion, or if you have high-grade other stenosis with reduced flow, and when you are confident that you can easily do a PCI in this specific setting. So immediate multivessel PCI, nevertheless, is clearly something you should not do because it is causing harm. It increases mortality. The key message is keep it simple, and then you are able to reduce the mortality of these patients with multivessel coronary artery disease and cardiogenic shock. And as you can see it here, culprit shock is now the largest randomized trial ever performed in patients with cardiogenic shock. In blue are all these trials which have been completed and published. And currently, the good news is there are more and more randomized trials which are currently ongoing in the setting of patients with cardiogenic shock, and probably the most important ones are those with mechanical circulatory support, because we do not have the evidence currently for mechanical circulatory support that it is reducing mortality. We are currently doing a trial with ECMO versus no ECMO or versus standard of care, and we have now randomized a little bit less than 100 patients. We have to go for 420 patients, and hopefully we will be able to present these data within the next 2 years, and hopefully we will be able to show that ECMO is reducing mortality for these patients who have still a very high mortality in patients with cardiogenic shock. So thank you very much. Thank you for attention, and I'm also open for discussions and further questions. Thank you very much.